So welcome to the keynote lecture. For people who are still getting coffee, if you have a cup of coffee in your hands and you see somebody else with a cup of coffee in your hands, please tap them on the shoulder and invite them to join the auditorium. So a key purpose of the Health Data Research UK Conference is exchange, dialogue and conversation between institutions and across organisations. So I was particularly delighted to be asked to chair this session and to travel 3 hours to have an exchange and dialogue with an esteemed colleague whose office is 10 minutes away from my own. I would like to say on a more serious point that Pearse Keane has made in two pivotal contributions, one in 2018 and one in 2023, advances which define the field of artificial medical intelligence. And that's the title of his chair. Pearse is a professor of artificial medical intelligence. There are, I think, few professors who can claim that in just 2 papers they've made such an achievement and helped define their field. I will carry on talking just for 30 seconds because people are coming in and I want people to be here when Pearse starts. So what I think we're going to hear about this morning at a keynote lecture is the journey from starting with labeled data and specific tasks in 2018 to unlabeled data and more general tasks, particularly in the field of diagnosis and prediction in eye disease. So I'd like you all to welcome Professor Pearse Keane for this keynote lecture.
Thank you, Harry, for that very, very kind and generous introduction. So, I'm going to talk about transforming healthcare with artificial intelligence, lessons from ophthalmology. Before I start, one thing I'd like to highlight is that if you see anything cool or exciting over the next 20 to 30 minutes, it's probably only been possible because of the support from Health Data Research UK. And so I'm really, really thankful to Andrew, to everyone at HDR UK for everything they've done for our work over the last few years. The other thing that I'd like to highlight is that I've got my Twitter or my X handle in the bottom right corner of the title slide. I'm always looking for more followers on Twitter, so if anyone would like to get in touch, please consider doing that. But for those who are more old school, on my last slide of my presentation, I'll give my email address. And so come up to me at the end and have a chat, or later today, but if you don't get a chance to, please do drop me an email. So I'm a consultant ophthalmologist at Moorfields Eye Hospital. I'm also, as Harry has said, a professor of artificial medical intelligence at UCL. And although I'm not a computer scientist and I'm not an engineer, I've somehow come to find myself leading a multidisciplinary clinical research group that aims to develop and apply artificial intelligence in healthcare using ophthalmology as an exemplar for other medical specialties. The other thing to highlight is that you probably are able to tell, but I'm originally from Ireland, and the reason that I've come to the UK is because of the support for clinical academics that's provided here. And so I'm funded by UK Research and Innovation, and these are my financial disclosures. Now, I'm going to talk about 3 things that I think are cool. So, first of all, start with why. Why do we need artificial intelligence in healthcare? Why do we need it in ophthalmology in particular? Well, I pretty much always start my presentations with this slide. So some people from other medical specialties can have a tendency to think that ophthalmology is a small medical specialty or kind of like a niche specialty or a cushy number in some way. But in fact, since 2017, ophthalmology has overtaken orthopedics as the #1 busiest specialty in all of the NHS in terms of clinic appointments. So nearly 10% of all clinic appointments in the NHS are for eyes. That's nearly 10 million appointments per year, and that's a number that's risen by more than a third in the last 5 years. And so if it's not too brutal a way to put it, we are drowning in the number of patients that we need to see and treat. And unfortunately, there are many patients that lose sight and sometimes go blind because of delays in being seen and treated. And so what I believe is that the use of data and technologies associated with data can help address these problems. But in no way do I think that this is some kind of magic that we can sprinkle. And I'm always an advocate, if there's a simple approach that doesn't involve any sort of high technology, that should always be explored first before we start to look at things like artificial intelligence. Now, of course, I'm biased as an ophthalmologist in saying that I think ophthalmology is one of the medical specialties at the forefront of AI-enabled healthcare. There's at least some objective evidence for this. So the very first autonomous AI system to get FDA clearance was in ophthalmology for diabetic retinopathy screening in 2018. And in fact, the second ever autonomous AI system to get FDA clearance was also for diabetic retinopathy screening in August 2020. Now, you could be forgiven for thinking with all the hype around AI that if you come to visit me in Moorfields that you'd see lots and lots of AI systems in use, and very sophisticated hospital of the future, for example. And I wanted to manage your expectations around that. And so I thought I'd highlight this paper that came out in the AI journal from the New England Journal of Medicine just in November of last year. And this essentially is looking at a very large insurance claims database in the United States. And I thought I'd highlight 3 key points from the abstract. The first point is that when they looked at it last year, there was over 500 FDA-cleared medical AI systems in the US. The second is that they looked at a claims database of 11 billion claims between 2018 and 2023. Now, the good news was that from my perspective, the second most widely used system was for diabetic retinopathy screening. And the first was for assessing coronary artery disease. However, those were the only 2 systems out of over 500 with more than 10,000 insurance claims. And the fact is that even for those 2 systems, the usage of them is still a drop in the ocean in terms of US healthcare. So we're still super, super early in these pathways. Now, my own experience came because back in 2015, 2016, I initiated a research collaboration with the artificial intelligence company Google DeepMind. Now, that collaboration involved sharing about 1.2 million anonymized optical coherence tomography scans with DeepMind. And so you can imagine the challenges that was required, leaving aside any scientific or clinical challenges, to aggregate and curate that amount of data. But also, little did I realize it at the time, how big an undertaking that was in terms of data protection, patient public involvement and transparency, and making sure that everything is done correctly from an ethical and a governance perspective. So in August 2018 then, after we had shared this data, we were able to work with DeepMind to publish in Nature Medicine a description of a deep learning system that could look at these OCT scans, the type of scan that when you go to your Specsavers or your Vision Express or your local optometrist and they ask you, do you want to pay an extra tenner to have this high resolution scan done? And essentially, we published it in Nature Medicine in 2018. And then, of course, this being AI, you can't escape the hype around it. And so you can imagine what it's like to be sitting on the tube and having people opposite you reading the Evening Standard and seeing something like that. And so, very nice, very exciting, because I can tell you in my career prior to that, I'd published a lot of papers that I put my heart and my soul into, and they were probably read by like 10 people. So nice to see that getting that kind of attention, but also a little bit awkward. Because the fact of the matter is the hype is with AI is both a blessing and a curse, because we hadn't saved the sight of millions of people. And in fact, in 2024, how many people's sight do you think we've saved with this AI system? Zilch. Zilch. And I'll tell you a little bit why that is. Although I should emphasize before I get too negative, the dream is still alive that we are going to do that. Just takes a little bit longer than we imagined. So let me just quickly show you the system. So this is probably not too exciting for most of you, but essentially you take your OCT scan, which is a bit like an ultrasound, but uses light waves instead of sound waves, gives very high resolution images of the retina. And essentially the AI system delineates all the pathology on the scan. And then on the top left, it makes a referral suggestion and it gives a diagnosis. So the idea is that if you have some potentially sight-threatening disease and you go to your local optometrist or your local comprehensive ophthalmologist, it can identify the people who need to see someone like me, or a retina specialist, and get them to have treatment in as early a fashion as possible, and thereby hopefully save sight. So while I'm kind of self-promoting and boasting a little bit, let me tell you about another quick high point, which was we published this paper. I'll tell you about the high points before I get to the low points. But we published this paper, and then the following Christmas, Hannah Fry was doing the Royal Institution Christmas lectures. And so we got to do a live demo in front of a few hundred kids in the Royal Institution of this. And we had our OCT device. We had Elaine Manna, who's a patient of ours who's been a huge supporter of the work, who has macular degeneration, who came and had this done. And so we did a live demo, and you can watch it on BBC iPlayer if you're interested. As it happened, the demo didn't work when we actually did it. It kind of crashed and burned. But the way they've edited it, it's not super obvious that it didn't work. But just to flag. So the other thing just to highlight then before I tell you about the challenges is we're very proud of the plaudits that we've received in terms of doing things right, in terms of governance and ethics and so on. And so there was an article in the Telegraph at the end of 2022, and it was about how Google had been sued for some other work that they had been involved with that we're not involved in. And I don't know the rights, really too much of the details of the rights and wrongs of that. But what was cool was that in the last paragraph of this, there was a quote from someone that many of you are familiar with, Phil Booth from Med Confidential, who's a real expert in data protection and patient privacy. And so he said, it's perfectly possible to carry out open, ethical, responsible science in health research that has real benefits, such as when DeepMind partnered with Moorfields Eye Hospital. And I remember reading that and going, thank you, because that was such a vindication of what the care that we had put over the last few years. Of course, which is not to jinx it for the future, because there's always a chance we could screw things up in the future unless we never take our eye off the ball in terms of doing things right in terms of these issues. So where are we now in 2024 with this system? Well, I thought I'd tell a little anecdote about this guy called Ken Cukier. Ken is a senior editor at The Economist. He wrote the book Big Data back a decade or so ago. And so in March 2021, he developed loss of vision in his left eye, and he emailed me, and we were in the middle of a lockdown at the time, and he emailed me saying, what should I do? And so I called him up, and essentially I told him to go into Moorfields Eye Casualty and get seen and get treated, and I was like the hero because I was able to organize this. But he went in, and he checked in at the receptionist, and he said, like, where's the world-leading AI system that I've heard so much about? And the receptionist just kind of like probably just grunted at him. And then he went to the nurse and he went to the doctor and he asked each of them, like, where's the world-leading AI system? And everybody was just like thinking he's crazy. Because, of course, the AI system is not actually in use. And so a few days later, he tweeted this, and this is public, so I think it's okay for me to say this, but he said, AI is a fraud. I went to Moorfields for emergency eye surgery, and instead of DeepMind's cool algorithms diagnosing me and robot surgeons, I had to accept the excellent skill, thoughtful care of human medical staff. What a disappointment. So, of course, he was both kind of like praising us and teasing us at the same time. And as it happens, the condition he had is not something we would diagnose with an OCT scan. However, the point remains that in 2021, the system was not there, and in 2024, the system is not there in actual real use. And so he kindly invited me to come on his podcast, the Babbage podcast, and talk a little bit about some of these challenges. So what are those challenges? Well, I think that as researchers, I think we're all kind of aware that it's one thing to do an in silico validation, but is that actual proper clinical validation? What type of other trials do you need? And then alongside that, what type of regulatory approvals do you need to use this as a medical device? But I think what's less clear to people are these other kind of what I call gnarly challenges around how do you integrate into information systems? How do you think of the business model? How do you think about implementation and adoption? So when I started this journey, I kind of had this perhaps slightly self-righteous kind of tone where I would think like, let's just focus on the thing with the most pressing clinical need, and let's not worry about business or anything like that, and let's focus on that, and that will lead to good things. But I've come to realize actually that if you want these AI systems to be used, massive amounts of ongoing investment will be required, and therefore the business model has to work. And in fact, maybe you should be thinking of what's the business model at a much earlier point in the process, just to be realistic about these things. So that's a slight caution about what we've been doing. But on the other hand, I'm still super excited. I feel like this is the most exciting time to be a researcher, and I compare it to the dawning of the electrical age. And so I've been reading a lot about Thomas Edison, and I think we have a tendency now to just think that all the innovation that's happened has just been in the last 20 years or in the last 50 years in the digital age. But actually, there's arguments to say that the 1880s were much more innovative than the current times. And so Thomas Edison, I read this article about Thomas Edison where it said that on September 4th, 1882, was the dawning of the electrical age. And that was when someone from the Edison Illuminating Company flipped a switch and the Pearl Street district of Lower Manhattan was lit up. And that was the dawning of the electrical age. But the thing was, Edison had his patent in 1879. And for the 20 years before that, there's more than 20 other patents, over half of which are for a carbon filament in a vacuum that's sort of broadly similar to what Edison was able to do. And so the genius of Edison was not just getting a longer lasting light bulb. The genius of Edison was realizing that it's about having a reliable source of electricity. It's about having a distribution system. It's about having a connection system. It's about having some sort of meter so you can measure the usage and you can have effective business models. And it's about having a network of innovations. And so at the moment, I feel like where we are is still just like inventors with a prototype light bulb, and we ask a journalist to come into a room and we show them the light bulb and we say, isn't this amazing? And then we kind of push them out of the room after a few minutes because then the light bulb fizzles out. And so, that's the analogy that I think I think there is something good if we can get this network of innovations. So we're building a new hospital in Moorfields. And so we're already thinking about the flexibility in the design of that hospital so we can take advantage of the new pathways that we think AI will allow. But for me, the real promise here is about how we can use AI to bring world-leading expertise out of specialized centers such as Moorfields into the community and potentially into the homes of people in the future. And this is not about replacing work, this is about upskilling work in the people that use these systems. So in the last 5 or 10 minutes, I'm going to tell you about 2 spin-off projects, or last 6 or 7 minutes. And they leverage what we've done in this work. So because of the collaboration with DeepMind, we built a cloud-based data infrastructure to aggregate and curate our data. We learned a hell of a lot about information governance and always trying to learn more. And we developed a lot more links with academic computer scientists. And so in September 2019, it was really amazing that we were able to get funding from Health Data Research UK to create the Insight Health Data Research Hub. And over the last 3 or 4 years, we have created by far the world's largest ophthalmic imaging bioresource. And just to tell you, by comparison, we have more ophthalmic imaging data from one center, Moorfields, than the top 5 eye hospitals in the United States. And that's a pretty unusual situation to be in. We also think that we've set high standards for governance. So we've worked with the Open Data Institute to have a data trust advisory board and with the charity Action Against AMD to do that. And so because we've learned a lot about governance, that has enabled a study that we call the ALAI study. And this is a study where we got people at Moorfields who had imaging done over a 10-year period, and we got permission to link that to the hospital episode statistics database, this national database. So effectively, we know anyone who's had an eye scan at Moorfields who's moved to Leeds and had a heart attack, or moved to Liverpool and developed Alzheimer's or Parkinson's or any systemic disease. And so we published our cohort profile in BMJ Open in 2022. And we're excited about this because we now know that with AI, you can look at a retinal photograph and you can say whether it's a man or a woman. You can say what age they are, whether they smoke or not. You can even give pretty good measures of their blood pressure. And we get excited about that because that's not something that human experts are able to do. So it suggests there's a lot of biological information that's still locked within this high-dimensional imaging data. So just to tell you some initial numbers, we have about 1.3 million linked hospital episodes, and we have about 10,000 incident cases of stroke. And compared to when we calculated it a year or so ago for UK Biobank, about 700 with retinal imaging, 12,000 cases of heart attack, and 13,000 cases of dementia. And so let me tell you some initial results. Earlier last year, we published a paper in JAMA Psychiatry and showed some changes in the retina in patients with schizophrenia. And then in August of this year, we published in Neurology a paper describing changes in the retina in patients with Parkinson's disease in the inner retina. And the exciting thing was that we were able to combine this work in the ALAI study with the UK Biobank study to show that there were changes present on average in the retina 7 years before the diagnosis of Parkinson's disease. So a last thing about this is that UK Biobank, when I looked a couple of years ago, had about 250 million in funding. And by comparison, the ALAI study was funded with a small grant from Fight for Sight UK and Alzheimer's Research UK for £15,000. So I call it Biobank on a shoestring. Now, I'm being very facetious when I say this because actually there's lots and strengths of Biobank and there's lots of weaknesses of the ALAI study. But what's really exciting is when we can bring them together in a synergistic fashion. And the other thing that I didn't tell you is it took us 4 years to get the permissions to make that linkage. Now, the reason why I think that this could be a game changer is because it turns out that when you turn 40, I found out a few years ago, you get a text message on your phone from your GP saying, come in for your cardiovascular health check. And it turns out that only about 9% of people actually take that up. And I was busy at the time and I kind of ignored it. But by comparison, about 80% of people will go to there and have an eye test done. So what if we could pick up some systemic disease? What would be the public health implications of that from routine eye tests? So then my last 2 or 3 slides, and I know I've talked for far too long, I just want to tell you about the work that Harry just mentioned at the start of his introduction. So the exciting thing about AI is that the progress has been accelerating. And it's both exciting and it's also scary. And to the point where people within the field, the leading pioneers of AI, are kind of like amazed at the progress that's been made in the last year or so. And The Economist wrote about this in July 22, and they talked about something called foundation models and how these models are turbocharging progress. And foundation models are a term that was described from Stanford in 2021. But everybody's so excited about them because of ChatGPT, which is a type of foundation model called a large language model. But these foundation models can deal with other forms of data, not just language. It could be images or omics or other data. And so we're very excited. Building on all of the things we've done before, we were able to create what we call RetFound, which is a retinal foundation model. And this is a model that we trained on just under 2 million images from Moorfields, unlabeled images, and we were able to show that we could fine-tune it for more than 10 different so-called downstream clinical tasks, like predicting glaucoma, or predicting a heart attack, or predicting Parkinson's, all from your retinal examination. The other advantage of using so much data is that we can do it in a way that's not just a good performance, but it's more robust, more generalizable, potentially fairer across different socio-demographic groups, and also more label efficient, which opens up the possibility of application in less common disease. And so in September 2023, we published this in Nature. And the thing that I'm probably most proud of with this is that we made the model code and the model weights open source. And so we're hoping that this can be a cornerstone for global efforts to use AI to prevent blindness. So as our next steps, we're going from 2 million to 20 million. We're making it multimodal, we're making it 3D, and we're exploring privacy-protecting technologies such as federated learning. And my last slide, I promise, just to say, as you can probably tell, I'm an optimist at heart. And so I love reading articles like this. This was in The Economist a few months ago. Many of you probably saw it. And you can see the BBC microcomputer. I don't know if anyone remembers those. But it was how to make Britain an AI superpower. And there's a lot of things in the article saying, well, actually, realistically, the UK can't compete with the US and China in many aspects of AI. But one of the only areas where they said, actually, maybe there's a chance here was in healthcare. Because if you think about it, we potentially have the NHS and we potentially have some of the top universities in the world. And I guess what I wanted to show, and if you don't mind a little bit of self-promotion, was that in the paper that I described published in Nature, we've made one of the first foundation models in medicine, and it's come from the United Kingdom. And if we can get our act together in the right way in the coming years, maybe we can be at the forefront of this revolution. That's it for me. Thank you very much.
Pearse, thank you very much for a tour de force of a keynote lecture. We do have some time for questions. I have one online from Ruth Milne about the environment. Power, carbon, water is the question.
Yeah, I mean, to be honest, I don't really have any very intelligent answer to that.
Okay, next question. Okay,
that's probably wise.
All right, in the room, who would like to ask a challenging or not challenging question? Kathy Sudlow. Microphones, and then there's one at the back there. Yep.
Pearse, that was wonderful. I've got a million questions for you, but I'm going to stick to one. So you told us about ALAI, which I've had the pleasure of hearing a bit about before, and it's a really fantastic resource. I presume that currently you run it in what anyone would refer to as a secure data environment, although it can't possibly be an NHS accredited one because there isn't an accreditation system yet. And I presume that's somewhere in Moorfields or possibly in a university where you keep the data, and I'm sure you have secure ways for people to access it and ways of protecting the identities of the individuals within the data. In what way does the rollout of secure data environments across the UK either challenge your model or provide you with new opportunities? Can I ask you for a really honest answer?
I always give honest answers. I think that So I think that there's still an awful lot of nuance around these secure environments that I don't think it's easy for us to say that there's a one-size-fits-all. And so one challenge that I would say is that I think it's important that NHS data can be accessed by UK universities. And at the moment, that is actually a challenge in many respects. And the single biggest supercharge of AI research in ophthalmology would be if UK universities could have access to NHS ophthalmic data much more easily than they do. And that's not always the case. So that's the first thing. And the second thing is, I think it's easy to just say, well, we can create a secure NHS environment for say UK academics to get access to. The practicalities are quite a bit more challenging than that.
Thank you. Question.
Hi, Susan Griffin from University of York. I was really interested to see how you were talking about the new tools and how they can recognize things that human practitioners can't. So I was wondering what you think the ophthalmologist of the future's job will be like, and what we would potentially need to do now to start training those ophthalmologists to work with these kind of new tools.
So I can't see you actually. Can you put up your hand? Oh, there. Thank you. Yeah, so I mean, I think that for the foreseeable future, that these tools are all pretty limited. They're pretty narrow. I see the ophthalmologist of 2030 I see, first of all, our clinics probably being just as busy as they are now, not having time for lunch, working late, et cetera, But I see the ophthalmologist having 5 different high-resolution imaging devices and having lots of omics data, and maybe they've got digital health data from like smartwatches and Fitbits, and maybe they've got like environmental pollution data from the neighborhood of someone perhaps in the future. And then I see us using a range of different AI tools to give some kind of output that we then have to integrate to make the correct decisions for our patient. And I think the important thing to emphasize is this is all like sounds magic AI now, but when these tools become available, within half an hour, you're going to forget that they're AI, and you're going to realize some of them work, some of them don't work, and you'll have to learn when not to trust it and when to trust these systems.
Question here at the front.
Thank you very much. It was a fantastic talk. I'm Rosemary Walmsley from Public Health Wales. You talked about the gnarly problems, and I was wondering what you think the AI team of the future looks like to take on those problems, what kind of mix of skills it has, and how you're thinking about training for the different range of people in that team.
Well, first of all, I should say I always wonder whether I should call them gnarly problems or not, or what people will think of that term. But so the AI team of the future, I'm not sure, but like I don't for clinicians like myself, I don't really foresee a future where you go to medical school and you have to learn like how to train a neural network, because like the fact is, if you ask any typical clinician define sensitivity, I bet you they'll be flummoxed actually if you put them on the spot to give that definition. So I think it's going to be again just about teaching them about the behavior of these AI systems and finding out what the strengths and what the weaknesses are for 99% of the users. And then for a smaller number, then I guess that's who are developing these systems, and that's a whole other ballgame.
So we have gone over time, but I think final question, please.
Oh, I'll have to make it a good one. I'm from the Association of Medical Research Charities, and it was great to see ALAI being funded by 2 of our wonderful members. In your talk, you referenced adoption and implementation as the kind of some of the gnarly issues, and I guess I'm interested in your call to action for researchers and funders, for that matter, in the room when it comes to what should they be thinking about now for adoption and implementation in 5-10 years' time.
So I'm not sure that I have any sort of particularly intelligent answer, but just maybe as a way to illustrate what I mean by adoption and implementation, because I went through it a bit quickly. We were, in Moorfields, we were looking at adopting a CE-marked AI system for a certain task in the hospital. And we potentially had free use of this system by the company that developed it. And it turns out that the device, you would take an image with the device, and the image would go to the cloud, and then some sort of output would come back. It turns out that that would take 2 minutes to occur in the best case scenario. And that was enough for us to decide not to go ahead with the pilot of this, because there's no way that we could allow for 2 minutes in the pathway. The nurse would have to take someone, take the image, take them off device, sit them somewhere else, bring them back, et cetera, et cetera. So it's thinking about, I guess, funding for, in answer to your question, about implementation science, health services delivery, all of those things is going to be really important.
Okay, thank you all for great questions, and thank you, Pearse, for a fantastic talk.
Thank you.